All right, what's up? Ken and Omertag, Lightboard video. This is the recurrent pregnancy loss segment. This is part 2. This is recurrent pregnancy loss, the workup. So in the first video, we talked about the definition of recurrent pregnancy loss and kind of alluded to the approach to the workup, said 50 to 70% of the time. Sometimes the workup shows nothing. So let's talk about actually what the workup is. So in the first, when you think about pregnancy loss, we got to think about what are the causes of why a pregnancy might fail. Well, the most common reason starts with genetics. 60 to 80% of the time, it's the embryo. The embryo is chromosomally abnormal. The chromosomes line up abnormally. They migrate abnormally. This is the most common cause of pregnancy loss, whether it's recurrent or it's just the first time. Most of the time, it's just an abnormal, random chromosomal abnormality. Now, the likelihood of that increases as the age of the egg increases, the age of the woman increases, but it's usually thought to be the embryo. The parents. So 4% of the time, one of the parents will have a chromosomal rearrangement. So if you took two chromosomes, let's say 18 and let's do a diamond here, 21. If you took part of this chromosome 18, this triangle, and put the triangle on chromosome 21, the amount of DNA in that parent is normal, but when that parent goes to make sperm or egg, they make more abnormal sperm or egg, leading to an increased inefficiency of reproduction and a greater likelihood of making abnormal embryos. So in patients who have 2 or more clinical losses, I like to check a karyotype on the parents to make sure they are normal 46XX, 46XY chromosome architectures without any structural rearrangements. Because sometimes those chromosomes can be rearranged, making the parent normal, but increasing the propensity of making abnormal gametes, sperm or egg, and then leading to abnormal embryos with higher frequency. So genetics is where it starts. Then we move to anatomy. And in the case of the anatomy, we like to do what's called a sonohysterography. This is a special kind of ultrasound where we put fluid into the uterine cavity, and we are looking at the configuration of the uterine cavity. Specifically, we're looking for a septate uterus. A septate uterus is actually a division, is kind of a muscle layer, or I'm sorry, it's not a muscle layer, but it's basically a dividing membrane that divides the cavity in half. So what ends up happening is you have kind of your cavity over here and then you have this avascular, no blood flow area that the embryo could implant on. And if an embryo implants here and tries to invade, it's not going to invade at all or very far because it's going to run out of blood supply or it's going to have an insufficient blood supply. So what we're looking for is a uterine septum. And the sonohyst is a very nice ultrasound. It's really simple. It is not like an HSG. It is a lot more tolerable. And it helps us identify the uterine configuration specifically. So uterus can come in different configurations. What you saw previously was normal. And then if you have this dividing membrane, that's a septum. So that's what we're looking for. We're also looking for scar tissue. We're looking for polyps. We're looking for fibroids. We're looking for filling defects, things that disrupt the endometrial cavity, can also disrupt implantation. So that's what we're looking for. Moving on, hormones. This is where we start to look for abnormalities with the thyroid, abnormalities with the pituitary gland. We'll look at a prolactin level. We'll check a TSH. We'll also make sure you're not diabetic. Check a hemoglobin A1C. These are just examples. Actual testing may vary from clinic to clinic, but this is what I do, and what a lot of us do. We'll check a thyroid level. We'll check a prolactin. We'll check a hemoglobin A1C. Now, the other thing we'll talk about is a lot of folks with recurrent pregnancy loss. Not everybody, but a lot of folks will have infertility. So a lot of what we do is also an infertility workup. Which is looking at your ovarian reserve, where we look at an AMH level. We might check an FSH and an estradiol, these markers of ovarian reserve that I've talked about before in the other videos on infertility workup. So that's an important thing to point out. Let me take a minute just to point out that some patients with recurrent pregnancy loss also have an underlying infertility. It might take them a year before they conceived, and then another year before they conceived again. So they might have some underlying inefficiency that meets the definition of infertility. Many times, people with recurrent pregnancy loss don't meet that definition, and still we'll check this marker of ovarian reserve to see, you know, are their ovaries acting older than their age? Is the quantity declining? Is that why their efficiency is less? So that's why we check those tests. Again, these tests are not perfect at assessing quality. They're just good at testing quantity. And then the final thing here is autoimmune disease, specifically looking for antiphospholipid antibodies and antiphospholipid syndrome. We typically, again, the academic approach is to do this after 3 or more losses. You'll see some specialists, high-risk obstetricians, some reproductive endocrinologists, some OBGYNs will do this testing after 2 losses. If you do it at that point, it may not be covered by insurance. It's more likely to be normal. So we usually try to wait for 3 losses before doing this testing, but many times we just test everybody. And again, there's variation, so talk to your doctor about what's right for you. And for those learners out there watching this, again, variation in practice, not unusual in this area. So this is kind of the basic approach to the workup in patients with recurrent pregnancy loss. Starts with genetic, we look at anatomy, we look at hormones, and then we look at autoimmune disease. And in the next video, I'll talk about the next phase of the workup and some of the more controversial areas of the workup.